Lecture 39, Experimental Psychopathology. Currently, psychiatric diagnoses are made on the basis of signs and symptoms, superficial manifestations of underlying pathology or disease. The various syndromes of psychopathology, schizophrenia, bipolar affective disorder, anxiety disorder, and the like, then represent clusters of symptoms and signs that tend to co-occur. In the medical model, a disease is a syndrome whose underlying pathology is known. That is, we know what's causing the signs and symptoms to occur. Scientific medicine treats pathology, not symptoms. In medicine, symptoms are not the disease, and progress in medical understanding is marked by a shift in focus from symptoms and signs to underlying disease processes, to underlying pathology revealed by laboratory analyses of structure and function, whose results are interpreted in the light of a theoretical understanding of normal function. Consider the example of fever, manifested by chills, a symptom about which patients complain, and increased body temperature, a sign indicated by a thermometer that a physician can observe. Well into the 19th century, the medical nosology included a large number of different types of fever, yellow fever, and so on, based on the symptoms accompanying the fever and the circumstances under which the fever occurred. But nobody diagnoses and treats fever anymore, because fever is viewed simply as a symptom of an underlying bacterial infection. Physicians may try to reduce a patient's fever as an emergency measure, but most of their efforts are devoted to identifying the underlying infection through things like blood tests, and then treating it through medications like antibiotics. The same logic applies to mental illness. In medicine, pathology affects bodily functions through lesions and anatomical structures like a skull fracture or lung cancer, abnormalities in physiological functions like hypertension or sinusarrhythmia, a heart condition, or infection by microorganisms like the influenza virus, or infections by bacteria or fungi or whatever. Modern medical diagnosis is based on evidence of these pathological conditions as revealed by objective laboratory tests, and there are parallels to this situation in mental illness, in psychopathology. So abnormalities in mental structures and processes are roughly analogous to the anatomical and physiological abnormalities encountered in physical medicine. In these cases of psychological deficit, something's gone wrong with the patient's basic mental apparatus, the cognitive, emotional, and motivational systems that govern the person's experience, thought, and action. Presumably, there's also some underlying biological abnormality that contributes to the abnormality in mental function. Then we have abnormalities in mental states, mental contents, the thoughts, feelings, and desires that are constructed by mental structures and functions. In some cases of mental illness, these mental structures and functions are essentially intact, and the abnormal mental states, the abnormal beliefs, expectations, thoughts, feelings, desires, what have you, are in some ways the mental analogies to infections. In medicine, underlying pathology is revealed by laboratory analyses interpreted in the light of our understanding of normal structure and function. In psychopathology, such laboratory research is known as experimental psychopathology. Experimental psychopathology tries to identify the causes of the patient's manifest symptoms. It is basic research on psychopathology, as opposed to applied research on diagnosis and treatment. Experimental psychopathology comes in two major forms. First, laboratory studies of psychological deficit. These studies take experimental paradigms developed for research on normal cognitive, emotional, and motivational processes, and use them to understand differences between abnormal and normal mental functioning. Studies of psychological deficit in schizophrenia have a long history, dating back to the experimental work of Emil Kraepelin, a psychiatrist who worked in Wundt's laboratory using Donder's reaction time technique in studies of schizophrenia. Like Kraepelin, modern researchers who conduct laboratory studies of psychological deficit hope that their work will lead to the development of new laboratory techniques for psychiatric diagnosis that will substitute for the symptom-based diagnostic procedures represented by the current Diagnostic and Statistical Manual for Mental Disorders. One highly prominent theory of schizophrenia holds that the psychological deficit underlying the patient's presenting symptoms affects the attentional system. According to this theory, schizophrenics suffer from a breakdown in selective attention that renders them highly distractible and unable to filter out irrelevant ideas. The patient shows thought and language disorder because he cannot keep track of what he's thinking and saying. He withdraws socially to shut out this chaos of stimulation. And in fact, laboratory tests confirm that patients with schizophrenia have a number of difficulties with attention. As you'll remember from the earlier lecture on attention, one of the prominent techniques for studying attentional processes employs the procedure known as dichotic listening. In this paradigm, different messages are played through earphones to the two ears, and the subject is instructed to shadow one message, repeating its words aloud as they're spoken, and ignore the other. There is little or no impairment when normal subjects shadow a single message with no distracting message coming over the other ear. But when the distracting channel is added, however, subjects make shadowing errors, omissions of parts of the target message, and intrusions of the irrelevant message. They also remember less of the target message and more of the irrelevant message. This is the kind of technique that can be used to study attentional deficit in schizophrenia by comparing schizophrenics and non-schizophrenics in their performance on the dichotic listening task. Comparing a group of schizophrenic patients to a matched control group of non-schizophrenic patients, Wishner and Wall found that schizophrenics were particularly prone to make shadowing errors. For example, they showed more omissions of information coming over the attended channel. And this is especially the case when the information was presented at a relatively fast speed. They also showed more intrusions of information coming over the unattended channel. Again, especially at fast speeds, but even at slow speeds. And finally, the schizophrenic patients showed poorer recall of the words that were presented over the attended channel. Again, this isn't particularly surprising if they were missing some of those words to begin with and distracted by words presented over the unattended channel. Again, the recall deficit is especially great when the information is being presented at a relatively rapid pace, but you can see it even in the control condition when there's no distracting information presented over the unattended channel in the first place. All of these results are consistent with the hypothesis that schizophrenics suffer from an attentional deficit. The dichotic listening results are pertinent to the question of auditory attention. Comparable findings were obtained in a study of visual attention by Sacuzzo and Schubert, employing what's known as the backward masking paradigm. This is actually a variant on the Sternberg procedure that we discussed earlier in the context of the visual icon and retrieval from the visual sensory registers. In their procedure, an array of digits or letters is presented very briefly so that there is not much opportunity for it to register in iconic memory. Presentation of this array is followed by a masking stimulus that effectively displaces the array from iconic memory, preventing it from being further processed into short-term or working memory. Therefore, identification of the elements in the array requires highly focused attention so that the subject can process the information from the array into primary memory before its representation disappears from iconic memory. In the Sacuzzo and Schubert experiment, subjects had to search for the letter T in an array of A's, or for the letter A in an array of T's. If it's present, they simply say yes, and another trial begins. The investigators then varied the stimulus onset asynchrony, or the interval between the onset of the array and the onset of the mask. Essentially, the amount of time that a representation of the array resides in iconic memory before it's displaced by the mask. All of this happens very quickly, from the time the subject focuses on the center of the display to the time the mask is presented. It's just about a second. And here are the results of the experiment. Sacuzzo and Schubert found that schizophrenics were generally poorer at target detection than controls, especially at the longer stimulus onset asynchronies. At the shorter asynchronies, nobody does very well. But at the longer asynchronies, the controls do better, for the simple reason that they have more time to extract information from the array. But the schizophrenic patients didn't seem to profit from this long stimulus onset asynchrony. Sacuzzo and Schubert concluded that it takes longer for schizophrenics to transfer information from iconic memory to short-term memory. By virtue of this slower rate of information processing, schizophrenics miss a lot of what goes on around them and are more distractible. So these findings from visual attention are congruent with the earlier findings with respect to auditory attention. Studies of dichotic listening and backward masking illuminate schizophrenic deficiencies in central mechanisms of attention. But attention is also regulated by peripheral mechanisms, as when we turn our heads or eyes or shift our attention from one object to another. Philip Holtzman and his colleagues studied the peripheral mechanisms of visual attention with an eye-tracking paradigm in which subjects are asked to hold their head in a fixed position and move their eyes to track a target that's moving smoothly across a computer screen. They then examine the subject's pursuit eye movements as they follow the target. Some aspects of these eye movements are not consciously perceptible to the subject, but they can be recorded by an electrooculogram, an EOG, similar to that used to record rapid eye movements in research on sleep or dreams, and also by other special devices. This measure of eye tracking provides a psychophysiological index of peripheral mechanisms of visual attention. Holtzman and his colleagues found that, in contrast to the smooth pursuit eye movements that are characteristic of normals, schizophrenics show eye movements that are much more jagged. About 70% of schizophrenic patients show these anomalous pursuit eye movements. But interestingly, pursuit eye movement anomalies like this also show up in the relatives of patients who are not themselves diagnosed with schizophrenia. Accordingly, Holtzman has suggested that abnormal pursuit eye movements might be a biological marker for schizophrenia, perhaps indicating an underlying malfunction in the frontal lobe of the brain, particularly those centers involved in the peripheral control of attention. Here's some sample raw data from one of Holtzman's studies so you can get a sense of what the data actually looks like, what these pursuit eye movements actually look like. Very smooth in the case of normals, very jagged and irregular in the case of the typical schizophrenic. And here's aggregate data from one of Holtzman's studies. You can see that the schizophrenic patients show a much higher density of anomalous eye tracking errors compared to a control group of patients diagnosed with one or another form of affective disorder. And that was also true when you looked at the parents of patients diagnosed with schizophrenia compared to the parents of patients diagnosed with affective disorder, even though these parents themselves weren't carrying any psychiatric diagnosis at all. It's this parent data especially that suggested that eye tracking problems were a biological marker of schizophrenia. Laboratory procedures can be used to study emotional problems in schizophrenia and other mental illnesses, as well as cognitive problems like attentional deficit. Remember that in Bloyler's original formulation of the 4 A's of schizophrenia, schizophrenics didn't just have problems in the cognitive domain, they also had problems in the emotional domain, what Bloyler called anhedonia, an affective disturbance in which patients simply don't seem to be emotionally responsive. Many schizophrenic patients show flat affect, no affect at all, or blunted affect. They show some emotional response, but not as much as normals. And still other schizophrenic patients will show inappropriate affect. They'll laugh at something that's sad, they'll cry at something that's pleasant. In one study, Anne Kring and John Neal showed schizophrenic patients and control patients a series of films that depicted either an emotionally positive event, a negative event, or an emotionally neutral event. They measured the patient's responses, emotional responses to these films, but when they did so, they were careful to measure all three components of an emotional response as defined by Peter Lang in the theory I discussed earlier. Self-ratings of the subjective experience of emotion, facial expressions as an index of overt behavioral response, and skin conductance, a measure of the electrical properties of the skin, as a measure of covert physiological response. When these researchers looked at facial expressions of emotion in response to the films, they found that, indeed, schizophrenics did not display as much emotion on their faces as the control subjects did. They showed fewer facial signs of emotion. The ones they showed were less intense and lasted less long. But interestingly, when they looked at the physiological measure, skin conductance, the schizophrenic patients seemed to be even more responsive to the films than the controls were. There was much more reactivity in the skin conductance measure. So here we have a kind of disjunction where the schizophrenics show less emotion in terms of their overt behavior, their facial expressions, but more emotion in terms of their covert physiology, skin conductance reactivity. Things got even more interesting when Kring and Neal did something that Bloiler hadn't done, which was simply to ask the patients how they felt when they were viewing each of the films. And when they did that, they found that, by and large, the schizophrenics reported feeling as much emotion as the normals, as the controls did. They felt positive emotion when viewing the positive film, negative emotion when viewing the negative film, pretty much the way the controls did. So here you see a good example of how we can use laboratory techniques to go from clinical observation to looking at real underlying pathology. It's not the case, it turns out, that schizophrenics have no emotional responses to things. They're not anhedonic. They feel as much emotion as anybody else, and those similarities go right to their physiology, what's going on at the level of the autonomic nervous system. The problem is that schizophrenics don't display much emotion on their face or in other aspects of their overt motor behavior. And this gives them the appearance of having flat or blunted affect. But when you take into account all three of the components of an emotional response, it's not clear that they have flat affect at all. You wouldn't know this from clinical observation, but you do know it from conducting laboratory research that's guided by a clear theoretical conception of the nature of emotion. In addition to studies of psychological deficit, it's sometimes possible to create laboratory models of psychopathology, inducing in normal individuals a syndrome that, in at least some respects, resembles some form of actual mental illness. Laboratory models are rarely, if ever, exact replicas of mental illnesses, right down to the last detail. Rather, they're usually content to mimic just one or more characteristic symptoms of some syndrome. An early example of a laboratory model is the literature on so-called experimental neurosis in animals that are being used in experiments on classical conditioning. In one experiment, a researcher working in Pavlov's laboratory presented dogs with a discriminative conditioning situation in which a circle was paired with an unconditioned stimulus, meat powder, but an ellipse was not, or vice versa. In either case, the animals eventually learned to make the discrimination, salivating to the circle, for example, but not to the ellipse. And at that point, the investigators began to manipulate the conditioned stimuli, making the circle somewhat more elliptical and the ellipse somewhat more circular. There came a point where the animal simply couldn't make the discrimination anymore, didn't know which stimulus to respond to. And rather than just sitting there, the animals actually showed terrific signs of behavioral distress. They looked like they were fearful or anxious. That's the experimental neurosis, a symptom of neurosis, fear, and anxiety induced in a normal organism, a dog in this case, under laboratory conditions. There developed a fairly large literature on these experimental neuroses involving not just dogs, but sheep and pigs and all sorts of other animals. And it turns out that the animals were okay as long as they could reliably predict or control the situation. At some point, though, as in the circle versus ellipse experiment, the unconditioned stimulus is simply not predictable anymore. And when the animal lost the ability to predict something that it had been able to predict in the past, it began to show signs of experimental neurosis. Later, in the 1950s, when Joseph Volpe began to introduce various forms of behavior therapy like systematic desensitization for phobias, psychologists turned to fear conditioning as a laboratory model for the development of clinical phobias. The idea being that the phobic stimulus, snakes, spiders, darkness, height, open spaces, whatever, serves as a conditioned stimulus that comes to elicit a fear response. Later on, the model became somewhat more sophisticated as investigators began to think about the role of vicarious learning, social learning, rather than the direct experience of stimulus consequences as lying at the root of phobias, and also to consider the role of preparedness in the development of phobias for that limited class of stimuli. Snakes and spiders, dark spaces, open spaces, and the like. Similarly, obsessions can be thought of as fear responses, in which the patient ruminates about the possibility that the stove has been left on or the door has been left unlocked or whatever. From this perspective, compulsions can be thought of as avoidance behaviors. Checking the stove or checking the door is a behavior that's designed to ward off the consequences of leaving the stove on or leaving the door unlocked. It has many of the features of an avoidance response. One of the interesting features of avoidance behavior is that it's very resistant to extinction. A dog in a shuttle box that's learned to move from one end of the shuttle box to the other in order to avoid shock will do so indefinitely. Every time the conditioned stimulus comes on, every time the tone comes on, the animal will just get up and move to the other side. This is true even after the shock has been turned off. And if you think about it for a second, you'll see why this happens. If the animal is avoiding the shock reliably, it never gets a chance to experience that the shock has actually been turned off and it doesn't have to do anything at all. Similarly, if you keep checking the stove or you keep checking the lock, you never really find out what the consequences would be of not checking. So fear conditioning looks like a pretty good laboratory model of phobias and obsessions, and avoidance conditioning looks like a pretty good laboratory model of compulsions. In a sense, laboratory models constitute theories of how symptoms arise in actual patients, because they're based on the assumption that the causative agents that effectively produce symptoms in the lab parallel those that are present in the real world outside the laboratory. Thus, laboratory models can be used to test proposals concerning the origins, treatment, and prevention of mental illness. And as such, any laboratory model can be evaluated on a number of dimensions. First, behavioral. Do the behaviors induced in the laboratory closely match the symptoms of the mental illness as seen in the clinic outside the lab? Conditioned fear pretty much matches what we see in phobias in the clinic. We also expect to see parallels in terms of causes. The kinds of causes we see in the laboratory case ought to find their parallel in the clinical case. One of the problems for the early conditioning model of phobias was that it just didn't seem to be the case that most phobic patients had the kinds of conditioning experiences that you'd expect to see based on the laboratory model. This problem was resolved to some extent when theorists began to think about the role of vicarious conditioning, social learning, not conditioning from the direct experience of contingencies between the conditioned stimulus and the unconditioned stimulus. Another parallel is a cure. Volpe, the behavior therapist, introduced systematic desensitization as a cure for phobias, and a very effective treatment it was. But systematic desensitization looks an awful lot like extinction. So there's a very nice parallel. The conditioning model of phobias suggests that the occurrence of phobia could be prevented by preventing the learning experiences in the first place, either by preventing the subject from having the direct experience of negative consequences of an encounter with the phobic object, or from having the kind of social learning that we really think now is implicated in the syndrome. And finally, we would hope that the biological substrates would be the same or similar or analogous in the laboratory case as in the clinical case. So, for example, in the laboratory, we can measure conditioned fear in terms of physiological responses like heart rate, acceleration. And we can do the same thing with phobic patients. In fact, one of the features of the behavioral treatment of phobias now is to measure the patient's fear response physiologically, not just in terms of self-report or overt behavior. One of the most interesting laboratory models of psychopathology is the learned helplessness model of depression. You'll remember from the lectures on learning that Martin Seligman and his colleagues discovered that prior exposure to inescapable shock interfered with escape and avoidance learning in dogs. In their analysis, prior experience with inescapable shock taught the animal that shock was uncontrollable, and this learning generalized to the new situation of the shuttle box. The learned helplessness experiments underscored the principle that in instrumental conditioning, the organism is learning to control its environment. The animals in these experiments learned to be helpless, but Seligman and his colleagues also observed that they looked and behaved as if they were depressed. If you've ever seen a sad dog, you know exactly what they meant. This led Seligman to propose that learned helplessness is a laboratory model for some forms of depression, that some people become depressed by virtue of a history of uncontrollable aversive events in their lives. Subsequent research by Seligman and others moved beyond this kind of anecdotal comment to identify a number of parallels between learned helplessness and depression. Depression, like learned helplessness, is characterized by symptoms of passivity, negative expectations, lack of aggression, loss of appetite, and sexual interest. And in both learned helplessness and depression, these symptoms dissipate with time. Some depressives, like the animals in the learned helplessness experiments, seem to have histories of life experiences in which they would have learned that outcomes were independent of their behavior. Depression, like learned helplessness, can often be overcome by treatments that change the patient's beliefs and expectations. And just as depressed patients respond to antidepressant drugs, so helpless animals respond positively to drugs that stimulate the norepinephrine system. Individuals who are relatively invulnerable to depression often have a life history characterized by many mastery experiences. Similarly, Seligman and his associates found that animals can be inoculated against learned helplessness by giving them prior experience with control. And finally, animals who have undergone learned helpless treatments give evidence of depletion in the norepinephrine system. So in terms of the kinds of features by which laboratory models of psychopathology are evaluated, the helplessness model of depression looks pretty good. The learned helplessness model of depression, as originally formulated by Seligman, is a pretty good model, but it's got some problems. For example, Lynn Abramson and her colleagues noticed that people who are exposed to unpredictable and especially uncontrollable aversive events don't always become depressed. Sometimes they become angry. Abramson and her colleagues proposed that it's not the unpredictable aversive events themselves that's the problem, it's how the person responds to them, how the person interprets them, and in particular, how the person explains them, a problem known as causal attribution. Abramson proposed that people who are exposed to uncontrollable aversive events become depressed if they explain those events in a particular way. Social psychologists had already identified three major dimensions along which people make causal attributions. First, to internal versus external factors. Did this happen because of something about me, or was it just luck or the work of somebody else? Stable versus variable attributions. Is this cause always present, or is it just an occasional thing? Global versus specific attributions. Is this a cause that affects everything, or does it only affect some particular aspect of my life? Lynn Abramson, Lauren Alloy, and their colleagues identified a tendency for depressives, or normals at risk for depression, to make global, stable, internal attributions concerning the causes of important negative life events. That is, they explained these negative events in terms of something about themselves, a stable trait that affected outcomes in a wide variety of different domains. If bad things are always happening to you, if there's nothing you can do about them, and if it's something about you that prevents you from doing something about them, you'd get depressed too. And that's the idea. Such a pattern of causal attributions is depressogenic in that it predisposes the person to react in a depressive manner to the occurrence of negative life events or to the absence of positive ones. In addition, Abramson and Alloy noted that normal people have an illusion of control. They think they're in control of events even when they aren't. In contrast, depressive people have a somewhat more realistic view of control. They're very quick to pick up on when they're not in control of things, and then they attribute this lack of control to something about themselves, as opposed to something about the situation outside. Abramson and Alloy identified this pessimistic attributional style as a risk factor for depression. It's a depressogenic way of explaining things. Now, of course, depression can be caused by lots of other factors as well, including purely biological factors like a problem in certain neurotransmitters. So Abramson and Alloy took another step, which was to identify what they called hopelessness depression as a subtype of depression. The helplessness-hopelessness theory is not a theory of all forms of depression. It's only a theory of a particular form of depression, what they call hopelessness depression. Now, while that may sound circular, it's really not. All Abramson and Alloy are arguing is that all depressions are not equal. They're not identical in terms of cause. Some depressions may be biochemical in origin. Other depressions may be environmental in origin. Hopelessness depression is a depression that has its origins in unpredictable and especially uncontrollable aversive events. Another prominent laboratory model of psychopathology underlies what's known as the dopamine hypothesis of schizophrenia. According to this hypothesis, the symptoms of schizophrenia and their underlying psychopathology are caused by excess activity of dopamine, a particular neurotransmitter substance. Now, in fact, autopsy studies and also some brain imaging studies indicate that there are increased levels of dopamine metabolites in schizophrenic patients, and that's consistent with the dopamine hypothesis. Moreover, the phenothiazine drugs, which are used in the treatment of schizophrenia, block the neural receptors for dopamine. impairing the uptake of dopamine by postsynaptic neurons. So the fact that there are increased levels of dopamine metabolites found in schizophrenic patients, and the fact that antipsychotic medications operate to reduce dopamine levels, these are both factors that are consistent with the dopamine hypothesis of schizophrenia. But another piece of evidence comes from a laboratory model of schizophrenia known as amphetamine psychosis. Solomon Snyder and his colleagues working at the National Institute of Mental Health found that the administration of certain drugs known as amphetamines can actually produce some of the symptoms of psychosis, particularly schizophrenia, in laboratory animals, including rats. They also noticed that the habitual heavy use of amphetamines by humans can produce some of the symptoms of schizophrenia as well, particularly hallucinations, features of thought disorder, and symptoms of paranoia, paranoid delusions. These amphetamine drugs have the effect of increasing dopamine activity in the brain. So this laboratory model, first in rats and monkeys, and then in humans who abuse amphetamine recreationally, provides further support for the dopamine hypothesis of schizophrenia. Research on psychopathy, or antisocial personality disorder, illustrates how the development of a convincing laboratory model of psychopathology can also stimulate studies of psychological deficit. And, for that matter, how studies of psychological deficit can influence the development of a laboratory model of psychopathology. The enduring tendency of psychopaths to engage in antisocial behavior and their persistent failure to respond to punishment has led to extensive research comparing psychopaths and controls on measures of response to aversive stimulation, avoidance learning, punishment, psychophysiological arousal, and the like. All of these experiments are essentially studies of psychological deficits in learning. And what they've shown us is that psychopaths are indeed not particularly responsive to aversive stimulation. They show a failure of avoidance learning, and they fail to respond appropriately to punishments when they're delivered. Interestingly, they learn from rewards, but they don't learn from punishment. They learn to approach things, but they don't learn to avoid things. What's interesting is that Ethan Gorenstein and Joseph Newman and their colleagues noted the strong similarities between the behavior of psychopaths and that of rats with lesions in the septal area. The septum is a portion of the limbic system. It's a subcortical structure, and it's known to be involved in the reward system of the brain. Animals with lesions in the septal area do not freeze when they're punished, and although they don't show a generalized learning deficit, they're rather poor at passive avoidance. They're poor at learning not to do something in order to avoid punishment. They're also very poor at delay of gratification. In short, these animals show performance deficits when they're required to suppress or alter habitual responses in order to avoid aversive consequences. They're very impulsive. So experimental psychopathology, using paradigms derived from the learning laboratory, can be used to explore some of the psychological deficits that seem to appear in the case of psychopaths. And rats with lesions in the septal area of the brain can be used as a laboratory model to study both the origins and the possible treatment of individuals with antisocial personality disorder. Another example of the links between laboratory models of psychopathology and studies of psychological deficit is provided by the study of hypnosis as a laboratory model of hysteria. Hypnosis is a social interaction in which one person, the subject, responds to suggestions offered by another person, the hypnotist, for various kinds of imaginative experiences. Most of these hypnotic experiences involve alterations in the monitoring or controlling functions of consciousness. Hypnotized people see things that aren't there, they fail to see things that are there, they remember things that didn't happen, they can't remember things that they did while they were hypnotized, and so on. What's interesting is that many of the phenomena of hypnosis show a kind of phenotypic similarity to many of the symptoms of hysteria. Following appropriate suggestions, highly hypnotizable subjects won't be able to see things that are right in front of them or hear what's said to them. They can show marked reductions in pain, what's known as hypnotic analgesia. They can be unable to move their limbs, a kind of paralysis or catatonia. And as I said before, they can wake up from hypnosis and be unable to remember any of the things they did or experienced while they were hypnotized. These experiences are subjectively convincing for the hypnotized subject, but there's none of the usual alteration in brain function. The hypnotically blind person doesn't have the experience of seeing, but his or her visual system is working perfectly well. The hypnotically amnesic person may have difficulty remembering, but there's nothing wrong with his hippocampus. These are some of the parallels between hypnosis and hysteria, because in the dissociative disorders and the conversion disorders too, patients will show functional impairments of consciousness, an inability to see, an inability to hear, an inability to move, an inability to remember, in the absence of any insult, injury, or disease to the brain. So at least since the latter part of the 19th century, large number of investigators have thought that by studying hypnosis and learning how it works, they might learn something of the mechanisms underlying hysteria, dissociative disorder, and conversion disorder. And in fact, when you experimentally investigate the phenomena of hypnosis, you discover that hypnotized subjects can show contradictions or dissociations between explicit and implicit expressions of perception and memory. So, for example, subjects experiencing hypnotic analgesia nevertheless show unaltered physiological responses to painful stimuli, and subjects experiencing hypnotic blindness or deafness or post-hypnotic amnesia will nevertheless show priming effects from the stimuli that they can't see or hear or remember. Based on this sort of evidence, investigators have looked for dissociations between explicit and implicit memory in cases of dissociative disorder, and dissociations between explicit and implicit perception in conversion disorders, so-called functional blindness or functional deafness. And in fact, when you test these kinds of patients, you discover that they have grossly impaired explicit memory, impaired explicit perception. They typically will show unimpaired implicit memory and implicit perception. The same kinds of dissociations between explicit and implicit that we see in hypnosis, we also see in so-called hysteria, in the dissociative and conversion disorders. That suggests that both hypnosis and hysteria involve a division of consciousness, and that we can use hypnosis as a laboratory model to study how that division of consciousness occurs. Experimental psychopathology is an interesting enterprise because it allows us to connect up the laboratory and the clinic, the scientific side of psychology and the applied side of psychology that tries to deal with problems of mental illness. Studies of psychological deficit allow us to move beyond merely the description of symptoms of psychopathology to understanding the pathological mental structures and processes that cause those symptoms to occur. Laboratory models allow us a new way of formulating and testing theories about the origins and treatment of various forms of mental illness. And finally, experimental psychopathology may allow us to develop new diagnostic tools for the assessment of mental illness. Just as physicians now employ laboratory tests to diagnose physical illness, so someday soon psychiatrists, clinical psychologists, and other mental health professionals will be able to move beyond diagnosis based on symptoms to diagnosis based on underlying pathology.